Good afternoon. My talk is going to be on how to treat or manage the unstable reverse. I'm going to start with some underlying beliefs about how reverse shoulder replacement works, and then go into specifically instability after reverse. So the normal shoulder has stability because of the dynamic balance of the rotator cuff pulling the humeral head into the glenoid, causing compression, which neutralizes the deforming force of the deltoid that wants to push the humeral head superiorly. Next. So if there's a complete loss of stability from the glenohumeral joint because of the deficient rotator cuff, you see the head shifts superiorly and you lose the fulcrum. And when that occurs, patients have a dissociation of the humerus from the glenoid. Next. And often they don't have a lot of deformity across the glenoid because there's not a lot of force across that joint since the head is no longer articulating. Next. And this is to be contrasted with those patients that have a rotator cuff there that develop significant cartilage loss. They too have a shift in their fulcrum, but they also have bone loss. Next. And they now have changes on the glenoid, often leading to bone loss, but they now have a bit more friction between the humeral head and the glenoid. Next. So there can be a distinction between patients that have instability with little cartilage loss, like the patient on the left, or those patients that have cartilage loss and have some degree of stiffness associated with their cuff tear that might, in fact, lead to instability after the reconstruction. Next. So one can posit that the reason a reverse replacement provides benefit to these patients is because of the increased constraint that you can see based upon the geometry of a deeper ball and socket as shown in this mechanical study. Next. So if you were to add the stability by using constrained glenoid, you'd still see that the shoulder would be unstable because of the vertical displacement of the deltoid being so strong that even constraint of the glenohumeral joint is unable to neutralize that deforming force. Next. So it's by reversing the articulation that provides stability. So when the deltoid is pulling the humeral head up, it actually now rotates around the glenosphere, causing this rotational moment. Next. So you can sort of see the difference between constraint of the joint and stability that's obtained by neutralization of deforming forces that cause the joint to dislocate. Next. So a reverse replacement can provide stability by neutralizing the deforming forces. If there's articular destruction, it allows smooth motion. Next. But you can still have instability after reverse replacement, and that's the focus of this talk. Next. We know that this can happen clinically up to 30% in some series, but is probably the most common complication that we see now that reverse has been utilized in such a widespread fashion. Next. When you look at why there is instability after reverse replacement, we've looked at this and came up with three separate mechanical reasons about why you would have an unstable reverse. One is there's inadequate compression between the ball and the socket. Two, there's loss of containment between the ball and the socket, or there's an impingement that causes the socket to lever out. Next. When we think about this, we came up with this classification by having 5 experienced shoulder surgeons look at a myriad of cases and agreeing upon the key mechanism causing dislocation. So this is how we came up with this scheme. Next. We know from some of the basic science studies that we conducted in our lab that compression between the ball and the socket is the most influential in terms of causing the force necessary to dislocate. So in this table, you can see an increasing amount of force needing to dislocate the joint, and that increasing force correlates with increasing compressive force. Next. So this is how we did this study. We made this rig. We had a ball and a socket. We can measure the dislocation force by a force on the socket, and we can measure the amount of compression. Next. And And as a result of that, we found that the more compressive force you had across this type of implant arrangement, the more stable the joint was. And there's some examples of what things may lead to inadequate compression. So one might be the lack of wrapping of the deltoid causing a compressive force. We can see that in these two different designs. Next. You can also see that if there's loss of humerus. You can also see that if the person is of a large stature, you can generally see where the lateral aspect of the humerus is relative to a plumb line drawn from the lateral aspect of the acromion. And if the tuberosity is medial to that, then you know that you might not have the same compressive force as if the tuberosity tends to be a bit lateral to that plumb line. Next. So another cause of instability is loss of containment. And this relates to the articulation between the ball and the socket. Next. So there's an example here of a patient that had instability, and you can see they wore away their socket, and as a result, they had loss of containment. And as you can imagine, the reduction in the contact area between the socket and the glenosphere led to instability. Next. Again, we looked at this in our lab in a virtual setting where we had virtually tried to change some of these parameters. Next. And it was very clear that as you increase the contact of the socket to the sphere, again, you had increased translational force. So many of the systems have constrained liners, and the way the constraint works is they have greater contact. Next. And this becomes more inherently obvious when you look at the contact area between these two. Next. You can see as you increase the contact area, like in these two, you have greater stability. Next. And next. Unfortunately, the increasing constraint can paradoxically lead to instability because of another mechanism, and this is the last mechanism that we described in our study, which is impingement. And the impingement can occur from a mechanical impingement, or it can cause from asymmetrical tightness. So you might have the scenario where you have a patient and you put in the implant so tight you can't dislocate it intraoperatively. Patient wakes up and they dislocate quickly. And that's likely because of an asymmetrical balance with tightness in the back, pushing the humerus forward or vice versa. Next. So this is just an example of how impingement can cause instability. You can see that gapping. Next. And you can see that in this cartoon as well, that again, if you increase constraint of the socket, you might, by doing that, reduce the impingement-free arc of motion, leading to instability. Next. So other things that become important in trying to assess patients who are unstable is understanding the impingement arc of motion. And this is one of our studies where we looked at the various factors that would lead to the best predictable increase in impingement arc of motion. And it's clearly related to a lateral glenosphere. So a lateral glenosphere with the center rotation laterally will always give you maximum impingement-free arc of motion. Next. And you can see that. Next. So when we look at what was most important of impingement-free range of motion, you can see the various things that can maximize that. Next. So when we looked at our patients that we treated that had an unstable reverse that I treated operatively, the most common reason was lack of compression, and then was impingement, and the last one was loss of containment. And by using surgical treatments to understand what the major cause was, we were able to keep about 85% of our patients stable who were currently unstable as a result of their previous surgeries. Next. And you can see that we did have about 15% that, even though we understood what the mechanisms were and we tried to address them with our surgical tactics, we still had 15% of patients that were unstable. And the ones that we noticed were the lack of compression often resulted in cases of an acromial fracture where, because the deltoid was detensioned, and we were unable to establish increased compressive forces even by building up the geometric changes in the implant. Next. Again, you can sort of see this is in contrast to others that have tried to address the unstable reverse, how they fared. And we believe that if you understand the mechanisms and you address the patient with a systematic evaluation, you're more likely to have a successful outcome. Next. So in conclusion, you can manage an unstable reverse by understanding the etiology and addressing it. When there's loss of compression, by lateralizing the humerus, either with a larger glenosphere that lateralizes it, or building up on the humerus by having more humeral offset, that can help. If the humerus is shortened because there's been the humerus has been shortened, you reestablishing length will allow that to occur. If there is loss of containment, then by putting in a new liner or understanding how the liner became damaged from some impingement can help. And finally, with impingement, it's important to understand if it's a bony impingement or if it's asymmetrical soft tissue issues. And usually the tip-off will be that you try to make the shoulder very tight and then it pops out. So you'd want to try to, when you're in the operating room, make sure you have a good balanced shoulder, and that is most likely to give you a satisfactory outcome. Next slide. So consider these factors when you're trying to address these unstable patients. Realize that you want to understand if the deltoid is non-functional as a result of either atony from a nerve injury or from a acromial stress fracture. These are much more difficult patients to satisfactorily stabilize their shoulder. Next. So in conclusion, reverse works by stability of the glenohumeral joint. It primarily works by neutralizing the destabilizing forces of the muscles that are trying to destabilize the glenohumeral joint. And instability can be obscured in patients that have coexistent arthritis. Next. Thank you for your attention. I hope you enjoyed this talk.